Good morning, everyone. Hi, I'm Dr. Sanjeev Socklingham, Vice President of Education at the Center for Addiction and Mental Health. And it's my pleasure, along with Dr. Leslie Buckley, who will introduce herself shortly, who's the Chief of Addictions at the Center for Addiction and Mental Health. And we're excited to be welcoming you today to the Opioid Use Conference for Primary Care. It's remarkable, really, to see so many people coming together, the speakers, the experience, the expertise, and the diverse perspectives at today's conference. Before Dr. Buckley and I begin with further welcoming remarks, we just wanted to note that we're located at CAMH, and I'd like to begin with a land acknowledgement of the land upon which CAMH is located. So CAMH is situated on lands that have been occupied by the First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs in places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. To land acknowledgement, I just wanted to say a few words, and I'll pass it on to Dr. Leslie Buckley for further introduction and welcoming. I just want to say congratulations to the Conference Planning Committee and speakers today for putting together a wonderful program, and also want to acknowledge the support from the Ministry of Health for funding to subsidize this conference. The last 2 years of this pandemic has had a significant impact on mental health and, of course, related to opioid use. Although the opioid crisis predates this pandemic by many years, the effects of the COVID-19 pandemic on this crisis, including the rise in opioid-related deaths and the influence of social inequities on opioid-related outcomes, have been devastating for so many people and families, which really has called all of us to action in terms of providing greater support resources now and beyond the pandemic's resolution. And I really see this conference as an opportunity to continue to bring together people with diverse lived and living experience, expertise, both clinical and more broadly, experience with advocacy and systems change so that we can learn from one another and continue to grow and discuss and have dialogue about how we might be able to share experiences, best practices, address stigma and inequities, and generate new ideas and approaches to low barrier, accessible harm reduction in opioid treatment services. I'm truly hopeful that today's conference will be part of that continued and shared learning, and that the discussions today will help us all advance our collective efforts during this critical time. And with that, I just want to hand it over to Dr. Leslie Buckley for her opening remarks as well.
Thank you so much for that wonderful intro, Sanjeev, and for the amazing work that CAMH education team and all our presenters have put into this conference. I don't have to highlight for anyone at this conference the importance of this work and this topic as we continue to experience an unprecedented crisis with continuing opioid poisoning deaths. The work, the innovation, the collaborations, and the advocacy continue, and today we'll have the opportunity to share and learn from each other. It's my great pleasure to introduce the co-chairs for the conference today, Abimanyu and Karan Cheema. Abby Sood is an assistant professor in the Department of Family and Community Medicine and co-chair of the Interfaculty Pain Curriculum at Temerity Medicine, University of Toronto. Abby also holds a research chair in primary care and population health systems at Humber River Hospital. Karan Shima is a nurse practitioner at CAMH, working in the Compass Outpatient Service. Compass is an outpatient service specializing in evidence-based medical and psychosocial interventions for clients with addiction, concurrent disorder concerns. I have the enormous pleasure of often working with Karan, who's a wonderful colleague and a true expert in this work. And without further ado, I'll hand the reins over to Karan and Abby, and I'm looking forward to the rest of the day.
Thank you so much, Leslie and Sanjeev. My name is Karan Cheema. I'm a nurse practitioner at the Center for Addiction and Mental Health. It is my great pleasure to welcome you all to 2022 Opioid Use in Primary Care Conference. We continue to grapple with this devastating opioid crisis and overdose deaths over the last 6 years now. As we seek a way forward, we need a multi-pronged approach to address this leading public health crisis. It requires strong collaboration across all sectors and focusing on strategies to reduce stigma, advancing opioid agonist therapies, decriminalization of drug use, and safer supply initiatives. This conference brings together stakeholders from all sectors, most importantly, people with lived and living experience, an acknowledgement that all experiences and voices have place in meaningful recovery and wellness. It comes down to people caring for people. We're here today to exchange knowledge and to improve our system of care. We're here to listen and to learn. Our scientific planning committee has worked hard to create an agenda for today, which is very exciting. I hope we'll all learn something to apply to our work or community. Thank you for taking time from your schedules to join us here today, and please enjoy the conference.
Thank you so much, Karan. And I'm so honored to have the opportunity to be a co-chair again this year for this conference. I have the distinct pleasure of making some acknowledgements for the immense efforts that have gone into making today happen. First off, I'd like to say a big thank you to all of our speakers. Thank you for gathering all this amazing knowledge and being willing to share it with all of us today. I always feel a huge pinch about not being able to attend all the sessions at this conference. There's so much that I know I'm going to miss out on today. But I know, like I did last year, I'm going to be digging into the recordings once they're available from U of T conference services. Last year, the pandemic allowed us to conceive of this conference as really national in scope, which I'm happy to see that we've maintained this year. At the same time, we are very fortunate to have speakers join us now internationally from France, Australia, and the US, reflecting on various aspects of opioid use, treatment, and policy. I would like to acknowledge Health Canada's Substance Use and Addiction Program for supporting this international orientation. Second, I want to make a big shout out to the amazing team at CAMH. That's Asha, Jennifer, Galit, Rosalicia, Robin, Lori, and many others behind the scenes. You've kept the wheels on this big bus that we've constructed together over the last few months. In particular, we're very grateful for your flexibility and support as the planning committee has continued to really paint outside the lines. This has been really, really valuable, I think, in making this conference happen and happen in the way that it has. Finally, I'd like to acknowledge the planning committee for this year. That's Sean Leblanc from the Drug Users Advocacy League, Sean Patenode from CAMH, Jillian Cola from the University of Victoria, Lara Nixon from the University of Calgary, Jairus Swidrovich from the University of Toronto, and Megan McGee from Sinai Health. It's really through your direction and efforts that today is even happening. In particular, I'd like to acknowledge the efforts of the committee to center the lived and living experiences of people who use opioids and to really try and normalize and destigmatize opioid use in how we've organized today's event. For those of you who've attended the conference in the past, you may notice that we changed the conference name from opioid use disorder in primary care to opioid use in primary care, recognizing that the term disorder itself can be stigmatizing and that much opioid use that should be of our concern is not disordered. This name change, while small, I think is meant to reflect a larger change in the orientation of the conference. And we look forward to your feedback as to how well this change has been achieved and how we can continue to improve along this trajectory over coming iterations of the conference. Thank you so much for joining us. And I will now pass it over to Sean Leblanc and Sean Patenode for introducing our amazing opening panel. Thank you.
Thank you, Abby, and welcome to everybody for our panel, Opiates to Advocacy. I'm just going to briefly introduce our panelists and our facilitators. My name is Sean Pathnode. I'm with the Patient and Family Experience Portfolio at the Center for Addiction and Mental Health. And our panelists this morning, Alexandra Kiewitt is an HIV positive and intravenous drug using woman born in the era of mustaches, macrame, and brown and orange tapestry. She's been involved in the community for over 10 years as a harm reduction nerd. She sits on several boards of directors, including that of the Canadian Association of People Who Use Drugs, which she co-founded, and that of the HIV Legal Network. She's also a facilitator and a Positive Leadership Development Institute member, and inspires people with living with HIV to get involved in their communities. She's amazed to have a harm reduction award in her name given while she was still alive. Ashley Smoke is a First Nations drug user and community activist. They do a lot of advocacy work and research with St. Michael's, U of T, U of Victoria, and the Dr. Peters AIDS Centre. They consult on a variety of projects with Public Health Ontario, Addiction and Mental Health Ontario, Mount Sinai, CAMH, Ontario Opioid Policy Research Network, among others. They helped create the Ontario Network of People Who Use Drugs and the Peel Drug Users Network. Michael Nurse is a passionate advocate of harm reduction and of the essentialness of lived experience to this work. He resides in Toronto, where he has been a peer harm reduction outreach worker for many years. And finally, our facilitator this morning, Sean Leblanc, left an abusive home situation in the Maritimes at age 13 and eventually put himself into university, where the loss of his pregnant partner started a decade-long run of addiction and homelessness. Sick and tired of being sick and tired, he used his stubbornness and desire for positive change to eventually found a nonprofit to advocate for drug users in Ottawa called DUAL, the Drug User Advocacy League, in 2010. He spent years as a frontline worker at Ottawa Inner City Health and is now a research assistant and consultant with Mount Sinai, St. Mike's, and a proud Canadian Association of People Who Use Drugs and Ontario Network of People Who Use Drugs board member. He is also a huge Red Sox fan and loves punk rock, harm reduction, bass guitar, and his partner Catherine, and is very happy to be here. And with that, I'm going to turn it over to Sean to start the panel.
Thanks very much, Sean. I should say that Sean's have it together this morning. We have a really amazing panel here. The amount of experience and expertise in these three people that are going to be addressing you next is just really amazing. I've learned from each and every one of them and continue to be in solidarity and just very, very honored that they're here today and are going to be addressing the panel. So I'll pass it over. Why don't you say maybe Alexandra first, if you want to have a few opening remarks.
Hi, everyone. First, I just want to acknowledge that I live, work, and play on unceded territory of Mohawk of Kanisatake and Atikamekw of Manawan. Right now, I'm in Saint-Jérôme in Quebec province. Well, I think my bio said pretty much everything. I'm a person who used drug. I'm really, I guess, I mean, I can talk about my drug use at work, and it's really important for me. And that's, I work in the harm reduction field. And a lot of time I see people that hide it, even in the harm reduction field. You know, it's like we promote harm reduction, but if we're like harm reduction worker that are not like higher as peers or at lived experience people, we have to hide it. And I think it's a nonsense. So yeah, I want to say I work in a place where it's really accepted, and I think that's how I can get help if I need any. If we're in that overdose crisis, it's in part because there's so much stigma that a lot of people have to use alone and cannot access treatment if they need. So yeah, I'm really happy to be here to share a bit of my experience and of my work. Thanks, Sean, for inviting me.
We're so happy to have you here, Alex. As I mentioned before, I've learned so much from you, and you've been, a continued inspiration for me, especially you doing this work when this work really wasn't being done. How about you, Ashley? Is there a few opening remarks that you'd like to have?
Hi. So, yeah, what brought me to activism actually was just like a decade-long battle with using drugs and not having any access to supports that were meaningful and useful. And then it got to a point where methadone was working, but everyone around me who was still using was dying. And it actually created my own relapse. And then I kind of started realizing that sobriety isn't me being well. Sobriety is me being well for the system and me being okay for everyone else. And then I was dead inside. So I think having this like role as activist, as speaker, as like, I don't know, advocate, I think it's really helped me learn who I am as a person and really helped me just like heal myself so that I can help others heal and be okay. If that means using drugs, then that's using drugs. If that means, I don't know, getting help and going to rehab because they don't feel good, then that's that. Like, I think it's important to help people where they're at. And that's how we start to help this opioid crisis. And that's not as prevalent in primary care as I see in harm reduction. So that's why I'm here today.
We're very fortunate to have you, Ashley. As I mentioned earlier, despite being significantly younger than me, you're very patient with my lack of tech skills, and you've taught me a lot. And speaking of teaching me a lot, we've got the Zen Master of Toronto Harm Reduction here, Michael Nurse. If you'd like to have a couple introductory remarks, we'd be much appreciated, Michael.
I'm not quite sure what I'm bringing today. Like, I've used psychoactive substances for many years, for decades. And I've used opiates as well, but opiates has not been, I would say, a major concern or a major consideration in my life. But it has formed the way I see and interact with others using drugs. And it has allowed me to develop a perspective on how we approach opiate use today. So I'm hoping that, along with learning from everyone else here, because I also recognize that there's a wealth of expertise and experience here today. So I'm open to learning from that, but I'm also hoping that I can add something that would enhance the whole experience here today. So thanks for having me here, and I look forward to it.
We're very lucky to have you, Michael. So we chose the title today, Opiates to Activism. Is there anybody who'd like to tell us a little bit about that journey? Or what was your journey like in going from a service user to someone who provides services? I don't want to overwhelm you with questions, but if anybody would like to take that, or even if there's a specific incident or person who got you interested in advocacy, we'd love to hear from you about it.
I'll go. So, wow. For me, I was in school and I was on methadone, and I was trying to figure out what to do with my life next. And I was going into nursing, and my teacher in the program I was in, which was community services, they were like, you can't go to nursing. This is where you need to be. And I didn't know why, but she saw something that I didn't see. So I went to my student placement, and I met a person named Natalie Kaminsky, and they taught me a lot about just like even who I was and why I felt the way I felt about like the shame and stigma of drug use. And like, so I think having someone who had been where I was and who was going where I wanted to go to show me that way kind of really helped me along in my journey. But the activism really started when people started dying, and my brother started using drugs and overdosing all the time. And then when I had to start, like, I was walking down the street and having to like Narcan people and do CPR on the regular, like it started to get to be a lot. So like I started looking at different ways I could make change, different volunteering options, different speaking engagements, different training opportunities, different ways I can get the word out of what we actually go through, and not what media tells you drug users are like, and what, you know, you see on TV and in the news. Like, it's not really like that. And I really hoped that the longer I spoke, society would just, hopefully more people would speak up, and the more of us that got together, the more change we could make. And 7 years later, we're still working on it. But I think this year has shown me, more than any other year that I've ever done this work, that our words and our experience is finally being sought after and like really taken to heart and taken seriously. And I think that's been that's very special to me, because I think I did this work for so long seeing no change. And I think the more that we take leadership in our own services and our own lives, I think that's the way out of this, if we can even get out of it. But that's the way forward, and that's why I do the work I do today.
Thank you so very much, Ashley. I just want to echo what you said. I also think examples like this conference and the amount of equitable and inclusion, from the very start is going to be a real way to change, this crisis and all this tragedy that people who use drugs are going through right now. What about you, Ashley or Michael? Would you like to talk a little bit about your journey to becoming a person who advocates for people who use drugs?
I feel like activism has always been a part of my life. Like, I've always been advocating and acting to change things in my life. I grew up in the Caribbean. I was born in Barbados. I grew up in the Caribbean, and there's this adage, I guess, that people follow, that children should be seen and not heard. And I'm not quite sure where the cutoff point is seen, because it seemed to extend way into my young adult life with my family. And there's also a post-slavery society where that sense of powerlessness is always there. But the activism for me comes from recognizing that change is possible. And I think that in the 1960s, I was in my teens then, connecting with the civil rights movement and the Black Power movement in the United States and also in Europe. That gave me a sense that change in regard to some of the things that I was experiencing is possible. But of course, that didn't last into my adult years, and disillusionment and so stepped in. And around 1986, I started on using drugs in a way that was really debilitating and harmful to me. Now, the thing that brought me in then to activism regarding drug use is harm reduction. It is recognizing that I could actually do something, that I had the ability to do something. And I feel like that was presented in the sense that it was possible to collaborate with others, and that the stigma that and shame and guilt that I was experiencing as a person who used drugs wasn't necessarily a barrier to working towards creating change. So that has always been with me.
Anyway, my question, I guess, what can doctors, nurse practitioners, pharmacists, and the like specifically do to help people who use drugs? Is there something that stands out to anybody on the panel?
In my experience, I think the best thing that doctors, like my doctor, I'm on Safe Supply now, but my doctor, she's also my primary care physician. And one thing I noticed is my doctor is one of my biggest advocates. And she'll go above and beyond, like things that my regular family doctor before wouldn't do. She's more than happy to fill out any forms, do anything. I don't have to pay for anything. I mean, I didn't have money for my meds, and like the CHC covered it. Like she advocates to my CAS workers and like all these different systems for me. Like, I think that's the biggest takeaway is be your patients or your clients' biggest cheerleader. Just be there for them. Be there in their corner for anything, even if their goal is to keep using drugs for the rest of their life. Just be behind them and help them, with any goals that they come to you with. And I think just meeting people where they're at and individualized treatment. That's the way to go.
Thank you, Ashley. Yeah, I couldn't agree anymore. I had a doctor that, despite, no matter how many mistakes I made or how many times I screwed up, he always believed in me and gave me faith until the point where I was able to start to have a little bit of faith in myself. We also welcome any and all chat questions. So anybody in the audience that has a question, please feel free to post them. How about you, Michael?
I think Ashley said it pretty well, what I was thinking. Thank you, Ashley, for highlighting those two things, meeting people where they're at and individualized treatment. I find that all service providers providing services to people who use drugs should become very familiar and able to follow that principle of meeting people where they're at. I find that too often, even when I'm not identifying as a person who uses drugs, I find too often I seek care and I am finding myself orienting to the type of care that the service provider wants to provide, and not so much to recognizing care that is responding to what I am seeking, what I'm asking for. I think one of the biggest examples I can offer is back around in the 1990s, feeling myself really in crisis with my drug use, and reaching out to a doctor that I saw in the Yellow Pages, that offered addiction care, medical care, and calling that doctor and being asked when was the last time I used, and answering early up in the morning and being told, well, if you really want to get my services, you have to be abstinent for 6 months. I mean, like, the care that I was seeking and what I saw that was being offered, there was a total disconnect. Like, he wasn't prepared to meet me where I was at. And I find that meeting people where they're at allows you to also to hear and to recognize what is being asked for, but also to tailor your services to what is needed. Too often the services are just there and they're put out according to discussions, maybe around practitioners and so, and things change. Especially in the world of people using drugs, things change and they change rapidly. So I feel like the only way to be able to offer services that are effective is to be able to meet people where they're at and to respond to people where they're at in a way that is meaningful for their particular situation.
Well put. Thank you so much, Michael. I believe we do have Alexandra back, and she also is going to give a few remarks about the question, about what she can tell people in the medical system.
When we go to care, people, a lot of doctor I had experience with just saw me as a junkie and a sex worker, once I was there for abscess, and they gave me my HIV diagnosis, and I was not expecting that at all. I didn't even know I got tested before. And they just gave me a flyer and they tell me to come back. And for us drug user, for a lot of us, just to go to the hospital is a big thing, because we're scared to be on withdrawal. We're scared to be judged and everything. And after that, after 6 months, I got really, really, really sick. And I had to go back to the hospital for a couple of weeks. And all they would give me for my opioid use was one Activism before I go sleep, which made me run away every day. I was running away from the hospital every day. And that's when I did my first overdose, because one of my friends brought me some heroin and I was so happy. I didn't really look. I was so like, I'm going to do it. And that actually put me in danger not to give me what I needed. And I was not there for a detox. I was there because I was going to die. I had a pneumonia. My HIV was really high, and the viral load and everything. So I think they have to listen to what we have to say. We know what we need. And a lot of time, like social acceptability passed before our right to live and our right to health. And because it's not good, say no to drug and all those things that stay in the head of people. it changed a lot. And I'm really happy to be able to give some training to doctors and to baby doctors, I call them, in university, and to nurse that study. And I saw some improvement. But I think they really have have a to have more like a harm reduction approach, like take us where we are and bring us where we want to be, and being pragmatic, like priority first. If you have no housing, no nothing, don't ask us to stop using. And like Ashley said at the beginning, for some people, abstinence is not possible. For me, abstinence mean I'm just thinking about dope, and by allowing myself to use, um well, I use a lot less than before, and because I work in that harm reduction setting, that is my passion. I mean, like I do a lot of things. I'm proud of myself, and I don't need to use. So doctors really have to listen to us and to make us partner in our treatment. Like not decide for us, but let us some choice. Yeah.
Well put, Alexandra. I guess we can turn it over to the other Sean, as we're often called on the organizing committee, who's going to shoot a question at you folks.
You absolutely cannot have too many Seans in any discussion, and this has been a great one so far. So a question that I wanted to pose, since we have both experts here and we have people in the primary care community, and this is for anyone on the panel, what's the biggest misconception that primary care providers have about the drug poisoning crisis? And answer that as widely as you'd like to take it.
That we take risk. I think they don't understand why we're at risk sometimes. One time I have my dealer I always go to. I know his stuff is good. There's no fentanyl, but one day I was in a bad mood and bad situation, so I went to buy from another guy, and it was fentanyl. And I did a lot less than I usually do, and I OD'd, and I ended up in hospital. And first of all, I was treated really bad. I asked them to go to the toilet, and they didn't want. I had to pee in the corner of the room. But they're like, they ask us like, why did you do it if you knew it was dangerous? So they have to understand that when, as a drug user, if I need to use, I'm going to take what's available. And sometimes, even though I've been working in harm reduction for 10 years, even though I know all to reduce the risk, well, sometimes I don't have no other choice than bad drugs. And even if I take care, if I, do a lot less, it's going to happen. And, they can tell, well, you should have known better. Well, I do know, but it can happen for many reasons. We don't plan to OD, we don't. It's not because we don't care. It's not because we're not cautious. It's because it's happening, like nobody choose to OD.
Thank you so much for that. And I don't think anyone could have said it better. Would anybody else like to talk a little bit about sort of misconceptions that primary care providers might have about the poisoning crisis before we get into some of the questions in the chat?
I think one of the biggest misconceptions I've seen is that abstinence is the only way. And like when you go to the hospital, like Alex said, they think like you're there because you want to stop using drugs, or like you're there because you don't want to use drug anymore. And sometimes that's not it. Sometimes you just want to like get healthcare. Like, I don't know, I went for my teeth one time and they're like, we can't give you opiates, but we can give you antibiotics. And I said, I have opiates, I need antibiotics. That's great, let's go. Like, so yeah, I think the biggest misconception is that abstinence is the goal for everybody, and it's not. And the supply is so toxic that I don't even think doctors really understand how it affects a person's brain when all those benzos are in it and you're not even like used to that. Like you can miss whole weeks at a time if you don't watch. So yeah, I think there's a lot of misconceptions to deal with, but those are my two biggest ones.
Thank you so much. I'll turn it back over to other Sean.
Thanks so much, Sean. I got a couple questions in the chat. I guess first one is here. What's the panelist's general day like? What's a typical day which one of you go through? You want to take it, Alex, please?
Well, I wake up, I feed my animals. I have a lot of animals. Then I dress, I brush my teeth, I go to work, and I go back home, watch TV with my boyfriend. It's a typical day like everybody else. But some of you will have a beer, some of you will have a glass of wine or a coffee. So sometimes I do have a bit of heroin, and that's the only difference, I think, because my life is pretty normal. I have a family, I have friends, I'm involved in a lot of committees and activity, so it's pretty like normal. It was not always the case. I once was in the street. I once was really disorganized. But why is it like that now? Because of harm reduction communities. Because I was given a voice. Because I was given a chance to be myself. Because I don't have to hide the way I am. And because people accept me as I am. And like that time I said I OD'd on fentanyl. I called my boss in the morning and I was crying and I was like, I'm so sorry, I can't come to work today. And when I came back to work the day after, he said, can I talk to you? So I went in his office and he just gave me a big hug and he said, I never want you to say you're sorry again. It can happen. I know it can. I knew when I hired you, it could, there could be some struggle. But I mean, I'm so happy you're alive. So that's a typical day for me now because I don't face a lot of stigma, but unfortunately, a lot of people still don't have access to all that. Thanks.
Thanks so much, Alex. We really appreciate your perspective on that. Another question in from the chat is, what do people think about having opiates and stimulants available like the cannabis is now available?
I think that we need that for sure, but maybe not in the same way. Like with marijuana, you get like 30 grams you're allowed to buy a day. Well, with opiates, some people's tolerance it's not equal. Like everybody's tolerance is different. Some people go through 2 balls of heroin in a day, and some people go through 2 points. So to make those like thresholds would be kind of detrimental to what we're trying to accomplish. But I do see the value and the need in, like, even for myself, being able to go to the store and buy your opiates. Like, that's where I would like to head in this world. I think being able to go buy your drugs without oversight from a doctor or a pharmacist, that's a harm reductionist's dream, right? So hopefully one day, but I think you need to consult people who use drugs in order to make that workable.
Well put, Ashley. Thank you. How about you, Michael?
Yeah, I agree with Ashley. I believe access to assured quality of substances is essential. One of the things that I always find challenging, especially in areas where I'm not familiar with the people who are providing the drugs, is being able to figure out whether I'm going to get quality or whether I'm just going to get nonsense. There's no way to predict unless you have a relationship with a person who you built trust with over the years. I feel like providing that, when you look at alcohol that came from prohibition to a point where nobody's talking about how much you can carry and that kind of stuff, that you see that the shift from causing people to use illicitly to allowing people access to short qualities is something that is essential, that is necessary. I wouldn't like to see it follow the cannabis model though, because I find that to be a bit lopsided toward the people who have made the investments into the financial investments into the businesses. So like people, the way that you access the cannabis is totally out of the hand of the user. You turn up and you get whatever's there. There might be fancy names, but you have no real way of being assured of the quality. So I feel like that needs to be changed. And the people who use the products should have, I would say, priority access to being able to source and supply the products. I find that two things that I find that could be encouraged in the changeover is, one of the things is that I know that when I go to people who know me, they would often make an assessment as to whether I am buying in a way that isn't harmful for me, or whether I need to consider something else. So they would say like stuff like, Mike, you're sure about this, or Mike, that and that, and we could have a conversation because they know my history. And it isn't offered in a clinical way or academic way that seems really distant. It is offered in a community care way. And the other thing is that if I didn't have money, that person can also assess my ability to pay if they give me credit, and I would be able to get that from them to suit the situation that I'm in. The other thing is that I can usually buy a small quantity if that's what I need. But in the cannabis situation here, you find that the market is shifting people towards buying at least a minimum of 3.5 grams. Where before you could buy a gram from a person who was selling. That is different now. So like the service is being driven by commercial markets. And I would like to see something different with the other substances, so that it is provided under an umbrella of community care by people in the community, of course connected to other resources, but led by the community, by people in the community. So that is something that I would like to see. But I do believe that access to assured quality is essential, and no amount of different programming and stuff is going, because when you're offering like user spaces and they're limited to certain times, and often limited to certain people, because I think recently there was one supervised consumption site that was open in Toronto that actually has an inhalation room with the opening. But often the safe supply is sort of equated with safer opiate supply. And there is a case of intentional use and unintentional use of opiates. So even there, find that the focus is narrow when we talk about safer supply, but it needs to be for all people who use substances. When you look at the changes that have come from ending prohibition of alcohol, I mean, it is just amazing, and we don't seem to reflect on that. Even the gang violence around when you had to protect your goods, when the law wasn't there to assist, even that changes, because now you would have protection for your goods and so on. So yeah, I think that a change that would allow access to assured quality, and that also ties into decriminalization too, because it also means that when I'm leaving home to go buy drugs, as Ashley quite rightly said, going to buy my drugs from somewhere that can offer me the quality, I don't have to worry about police waiting around the corner to arrest me and criminalize me for doing that. So change is definitely needed in how people access these supplies.
Thank you so much, Michael. You made some great points there. I also brought up decriminalization. Would any of our panelists like to have a few words about that?
I think we definitely need decriminalization, but like I said before, it needs to be led by people who use drugs, and we need to be the ones like creating these policies. We need to be at the table with the heads of police and like firefighters and the paramedics and the doctors. Like, we need to be there at the table. So I think it's important, but also like decrim for sex workers didn't go so well, right? So I think we need to, we can't just like rush into it. We need to really systematically figure it out and not just like demand it without seeing what the plan is first, right? Because at the end of the day, the government makes the plan.
Thank you, Ashley. All right. I actually have a segue into that same question too. What would you, the panelists, say about the right level per se of regulation of legal substances, like vending machines, like maybe you can walk into a store, or only through doctors? Would you like to take that, Alex?
I don't know. I don't think there's a right level. Of course, alcohol is legal and it causes a lot of debt, but people have a lot more access to help, and there's a lot more things that we can do around. There's less. There's no. There's. It's like there's less shame of being like an alcoholic than a heroin. Like a heroin user. I don't know if you know what I talk about, but it's not a question of level or whatever, but it's more like to normalize drug use in the society, so that reduce stigma, and that's how people can get help if they need to, if they want to, and that's how we can create a program around all that. But that's my point of view.
Thank you, Alex. What about one of our other panelists? Michael wants to give it.
Can I come back to that again?
Yeah, for sure. Please do.
So in collaborating, let's say, with a doctor, collaborating with another user, but particularly with someone who doesn't use drugs, who doesn't have that lived experience. For me, there's always that uphill thing of finding an equitable place to collaborate. I feel like that is what needs to be shifted. For me, there's a basic premise to most of my work, and it is that people use drugs. I mean, however you look at it, from generations way back into now, people use drugs. I find in my own experience with people around me, and so the desire, the interest in experiencing the altered consciousness, in experiencing shifts in consciousness is there, and I believe it's going to be there forever. The question is, how do we support people in going through these experiences and reducing the risk of harms as much as possible? There is where the shift, I think, is required, because I find that in most cases, when we don't approach drug use as that people use drugs, that there's this tendency to see people who use drugs as fucking up, as, hey, you're not doing what you're supposed to do. And then there is this response of either, hey, let you fall on your own weight, on your own consequences, or let's do something to protect society, let's do something to protect the neighborhood. So there is never really that clear offer of let us collaborate from where you're at. And I find that is the fundamental thing that needs to change. People who use drugs when we speak about harms, I find that one of the major harms is criminalization. Because it doesn't just impact me in the act of possessing the drugs, it impacts me in finding employment, in finding housing, in being a parent, and it also impacts generations after me from the trauma that is brought forward by the absence in family life that is brought forward by that. The only people who can really inform this and can lead this is people who live it. I mean, Bob Marley was saying, who feels it knows it. I like to change that to who lives it knows it. And I feel like that is the basic principle where things need to begin. But none of that, but nothing is going to change unless that is where we start from. And it has to be a living connection. It cannot be just a needs assessment that is very static, that you do it and then it is done, but life continues to change and change and change. So it has to be an involvement, a collaboration. Too often I find that we see the work that people with lived experience, people who use drugs do, we see that as employment. And often it only has a value when it is being done in connection with an agency or established service provider. But I want to suggest that this work is not employment. This work is actually a calling from within. It is a response to the community. It's caring for your community. And in essence, you are a part of that community. When people do work for organizations in harm reduction, we are based in the community. We're hired for that reason because we're based in the community. But yet that connection seems to be trivialized. One of the things I found during COVID is that when agencies closed and programs were changed, what I experienced personally is people who in my neighborhood recognized me as a person connected to harm reduction work began to come to me personally. Even friends that I've had that were struggling so and so, I brought people into my home, and it was probably one of the most challenging things that I've done, and I'm still dealing with that even today, because we live this work. This is our lives. As a part to this is our job. This is our lives. And when the position, often it ends very abruptly, when the position with an agency comes to a close, it doesn't end your relationships in community. And sometimes, often, how you set boundaries when you work for an agency has to be reassessed. And so after you're no longer working with the organization. So I believe that the essentialness of that involvement of people with lived experience in leading their own lives is something that needs to be recognized and honored. And for me, that's the only thing that's going to bring fundamental change. When we begin to see, as the Mayor of Toronto said this morning in regard to truth and reconciliation efforts, nothing about us without us.
I echo that wholeheartedly. Thank you so much, Michael.
Sorry.
Please go ahead, Ashley.
I just want to say something for both what Michael was saying and the previous thing about the regulations and the levels. I think it's not so much about the regulations. It's not so much about like all of the decrim, like the all the policies and stuff. It's more about like options, and people need options. Like some people like to go to their doctor for drugs. Some people like to go to the street for drugs. Some people like to go to the dispensary for drugs. Like everybody's different and everybody has different needs and wants. And I think that needs to be reflected in regulations and decrim policies and all of it.
Thank you so much, Ashley. We're going to go to the other Sean now, and he's going to allow me some time to take a bathroom break, thankfully. Go ahead, Sean, please.
Always happy to help. All right, so we are just reaching the last 10 minutes of our time together today, and something I would like to hear about from each of the panelists, if possible, because we have this audience together, is that what is the single most helpful thing that everyone attending this panel could do to better serve people who use drugs? And bonus points for if it was something that people can leave and start doing today.
Well, just to learn what is harm reduction approach, and to one of the most important thing when you work with people who use drug, I think it's the way you welcome them. We're not a number, we're a person with a story, and there's as many individual as there's story too. So we're all different. We're not like all the same person. We're not all like the drug user is not one type. And I think to welcome us and to listen to what we have to say, and to make us partner, like I said, in whatever we have to do together, I think that's the better thing. But really, like, to reduce stigma and to have a non-judgmental approach would be the better thing.
To listen, to partner, and to not be judgmental. Ashley or Michael, would you like to add?
Alex covered it well, the finer points. And I would just say and it's not just about people who use drugs, but to value the humanity of others, to recognize that each person is a valuable member of our common humanity. I think that if we can see people who use drugs as human beings, I mean, when we're not using drugs, who are valuable members of the humanity, our common humanity, that it would go a long way in changing the way that we interact with others. Like, would I speak or refer to that person in the words and stuff that I just did? If I was doing it about myself or about my mother or about my sister, about my brother, like, what makes that person less a human being than I am, or that the person that I care about is? And that begins to raise questions about my own personal biases and where they're coming from, and why am I treating this person that way, and what do I need to do to change? I think, yeah, to start seeing people as members of, of humanity.
Well said. And Ashley, here we come.
I think I would say kind of the same thing. Like, when you see your patients or your clients or whoever, just ask them about their day. Ask them how their day has been. Relate to them on some level. Like, just even if it's about a baseball game or the weather, like, make them feel like you're interested in what they're going through, instead of just getting your job done and getting rid of them. Because that's how we feel a lot of the times, especially in like doctors' offices or hospitals. So yeah, I think just like ask us how we're doing and just connect with us on a human level and empathize with our situations.
Thank you. And I think you led into a question that honestly I wasn't sure I was going to ask, but maybe we'll just turn it around a little bit. So someone had asked about counseling and if you'd engaged in counseling and if it could be helpful. And, I think that there might be a little bit of an assumption here that the use is disordered, but what I'd like to ask maybe instead is that this has been an incredibly difficult 2 years on top of an incredibly difficult, I think I heard 7 years and 10 years of this work. What kind of supports and emotional supports could be provided to people in the harm reduction community that you're not seeing now? And how could maybe, counselors and support and other support staff really sort of help you deal with this amazingly difficult load you've chosen to take on?
Well, I'm in counseling times three different counselors I see. Also, I think what I'm trying to start, but like a support group for people who use drugs, that we can just like connect with each other around Ontario and just like talk about what we go through as advocates and as activists. I mean, Ontario Network of People Who Use Drugs, we had a focus group and we invited 20 people around Ontario who do this work. And that's the one thing they all wanted, was a network where they could, like, a little meeting once a week where they could go and talk about these things, debrief, get supports where they're needed. And yeah, I think just like a peer led initiative where we can counsel each other and kind of help each other through this stuff, because that's what's lacking right now. There's a lot of like siloed stuff happening and we're not all connecting, and I think that's what's missing.
Yeah, I agree with Ashley, and I think that first, people don't have. We don't have to assume that we need to be saved. We don't necessarily need help because we're using, but in some situation we do. And for me, what's missing the most right now, it's help with grief, because we lose so many people during that crisis, and there's not really anything existing. Well, not in my area. There's not really nothing that exists to support like people who peers and frontline workers about grief and loss. So that would be really something that could improve our situation.
Thank you so much. Michael, did you want to say anything about that?
Yeah, just adding, that the support, especially around emotional wellness, is so important. I find that for me, often the work triggers reconnections to experiences that I haven't fully processed, or that leave me feeling hurt, stressed. And often there's no way to, particularly now, there's no way to turn. Like I find the work before, that personal connection, that being in the same space allowed for sort of impromptu check-ins, and people could read where you're at, and you could read where others are at, and you could share that. But that isn't there. And there hasn't been any real commitment by organizations to provide support in a consistent or meaningful way. Honestly, I feel that when funding is given to organizations that indicate that they're going to collaborate with, often it isn't collaborate, but they're going to collaborate with people who use drugs or people with lived experience, that there should be a contingency, that there should be a condition that they demonstrate that there is effective and meaningful support, emotional support for people who work in order to access this funding, because often it isn't there. I know like in Toronto where they've got the wellness project. I think it's coming out of, my mind is failing me, but I know that they have a good program, and one of the things, a couple of the things that come out from it is that people who access this support, it is not being done within the organization where you work, which sometimes can be a real challenge, to be telling people in the situation that you're in, where you're facing. And it is also the offer of more than one option, a choice, like Ashley said, choices of counselor that you could connect with. And those two things. There was another one, I don't remember what the other point was. But the point I'm trying to make is that support is necessary. It is essential. But often it isn't factored in as such. It is sometimes it's like an afterthought. And I feel like that occurred because there was this vibrant and robust connecting with each other as we did this work. But that has been disrupted. And I find that going forward, I mean, even now, like how we do, like if this was a conference like before, I might probably have a few minutes to sip a coffee with Sean or with Ashley and tap into things that I might not say here. But it is not easy to do in this setting. So there need to be a focus, a concerted focus on how we are supported. And the other thing too is that I feel that one of the things that COVID has brought out is that we as people with lived experience, that we, before COVID, have been supporting each other to stay alive and to navigate some of the challenges that are there. Now, with the changes that has occurred to organizations and the way that services are provided, I find that we are in a place where a very unique place, where we can speak to and need to speak to how do we move forward. It cannot be a return to normal, because normal hasn't been working for us. But we also have some ideas of how we've been able to support each other when organizations drop their services or just simply change them. So I believe that we need to harness this right now, where we're at, and not as separate from academics or clinicians, because I believe, like I've been saying, this is a collaboration. But to see how we can work together to bring these things in, but also lead in how that development goes. But support is definitely essential, extremely essential. And just to add to the other thing too is why I say to it is essential, because often outside of the work within agencies as a peer or a person with lived experience, often in the other fields, there's access to benefits that allow you to get these supports. Often with people with lived experience, there are no such benefits. So to get those supports built into the project is essential, because otherwise they're not going to be there.
Thank you so much. And we've reached our time, and I wonder if I could just ask all of the panelists just to turn your cameras on for just one last minute. And I ask that because I just wanted to offer my own deep thanks, and I'm sure those of all of the attendees here, for sharing your knowledge and your honesty and your courage with us. And most especially, thank you for the work that you have been doing and continue to do. It's never been more vital. And with that, I'll turn it over to Sean if you have anything that you wanted to say to the end of this, and thank you for this discussion.
Just, I guess, beyond our names, there's a lot more similarities. I agree in everything you said. Your resilience, your courage, your expertise in these issues. continues to inspire me. I just want to thank you from the bottom of my heart for sharing and sharing so bravely. And I'm looking forward to the rest of the conference. Thank you, Ashley, Michael, and Alexandra, and the other Sean, and everybody who's attending.
We're just here because, like, let's just bring it back to the fact that how many people had to die for us to be here. That's what I like to end on every time, because, like,
Well
it brings
said.
us back to reality. So yeah, remember all those people.
Thank you.
And thanks to everybody for allowing me to share this panel with you this morning.
Thank you, Michael.
Thank you for the opportunity to have a voice here today. Thank you.
Thank you all very much.